When I was diagnosed with breast cancer, I was 28 years old, and it came as a big shock to me as we had no family history of breast cancer on either side of my family.
I think there's still a misconception that breast cancer is an older woman's disease.
I found the mass and I went to my family physician. He recognized that I was panicked right away, and he had me consult a surgeon right away. And within a day I was having an ultrasound and a consult with a surgeon.
I think when we give people, patients, more information, and explain it clearly, that we empower them. I think we're really moving away from an era where we tell patients what to do, and rather than now where the patients are much more engaged in that conversation and making that decision.
You know you best, you know your own body. It's really important that you're there, active in the conversation with your doctor.
Ductal carcinoma in situ, or what we commonly refer to it as DCIS, is a non-invasive form of breast cancer. Women who have DCIS are at very low risk of actually dying of breast cancer.
Young women can and do get breast cancer.
The most important thing that newly diagnosed women with DCIS need to know, they're potentially at risk of getting breast cancer in their future. And so they need to better understand their own risks of getting breast cancer in the future so they can make the right decisions about reducing that risk.
It's such a confusing situation to be told you have DCIS. Is it stage 0? Are we treating it? What's going to happen?
There are patient preferences. People have personal preferences about what treatments they will accept, how much risk they will accept or won't accept.
The most important questions for a patient who has been diagnosed with DCIS would be, what is DCIS? How are we going to treat this? And are there any tools available that can help me make a treatment decision that's going to be important for my particular situation?
Prior to the Oncotype DCIS score, we would give women an estimate of what we believed to be the risk of recurrence. The DCIS score has taken us one step further and given women what we call personalized risks of recurrence.
There's comfort knowing that there's a tool out there, a test you can take, that can help you make treatment decisions.
If a woman has a high risk of this coming back, she wants to know that so that we can treat her effectively and lower that risk. If she has a very low risk of this coming back or getting breast cancer, she wants to know that so that she can avoid unnecessary treatment.
So I think having a test and having resources available to me before any of those decisions had to have been made would have really changed my outcome.
What our research findings showed is that when we incorporate the DCIS score into the estimate of risk, in addition to the patient's age and how big the tumor was, when we incorporate the score, we could better identify women at really low risk of recurrence who derived a very small benefit from radiation treatment.
I would definitely recommend having a genomic test if you were to find anything suspicious. Really puts everybody at ease. I think that element of worry and fear really contributes negatively to our health, and that if we can avoid that and really be proactive in our care, then we can avoid a lot more aggressive and invasive treatments that may not be necessary, that we can catch things earlier and avoid all of that.
Any test that moves us forward to more accurately identifying risk and engaging women in a more accurate conversation about risk and benefit of treatment is very satisfying.
So my life now is very different from when I was diagnosed. I was very young and had a little condo and was living the downtown life. And since then I have become a married woman and I have a 6-month-old baby at home.
To learn more about genomic testing for those diagnosed with DCIS and the importance of risk assessment in guiding future treatments, visit these websites.